Welcome, everybody. We are thrilled to have you join us in this APAC webinar, Beyond Statins, the next generation of lipid therapy from clinical trial to clinical practice. I am so excited to have some amazing board members on with me today, and they're going to walk us through all the tools we have in our toolbox to really help our patients. So our agenda is simple. Let's cover some of the pivotal trials in non-statin therapy and some cases, real-life cases that we have seen in our practice and how to get these medications to our patients. We're going to start with introductions of John Giaccona. He is a PA, PhD, CHC, who will be talking about ezetimibe. I will be thrilled to talk about bempedoic acid and talk about the pivotal trials. I'm a clinical lipid specialist and diplomat of the American College of Lifestyle Medicine and director of the Lipid Clinic at Park Nicollet. I'll pass the torch to Kevin Niles, who is a doctor, has his doctorate of PA as a PA, and we'll be talking about PCSK9 inhibitors. Via law, many of you know, we'll be talking about inclisiran as a great therapy for our patients, as well as all of these tools. And lastly, wrap it up with icosapent ethyl and Camille Dyer, a doctor of medical science as well. We are just thrilled to have your experience, your insight, your expertise. Some of us practice in clinics, some round in the hospital, some have industry experience, and I'm just really excited to hear what everyone has to say. But I think a good place to start is really, how are we doing? How are we doing in prescribing the mainstay of therapy to our patients, which is really statin therapy, which have been around since the 1980s. Unfortunately, not well, which is why we are bringing this important webinar to all of you. Patients who had recent acute coronary syndrome, who should have been seeing cardiology in the last year, less than half of them were on high-intensity statin, and 21% of those high-risk patients were on no lipid-lowering therapy. You can see the use of the non-statins at this time, when this review came out in 2022, was dismal for ezetimibe or PCSK9 inhibitors, 5%, 1 or 2%. And for patients living with peripheral arterial disease who experience the most social determinants of health, 50% were not on any lipid-lowering therapy. We have work to do, and that is why we're excited to tell you about some of the therapies we can use to fill in these gaps. So I'll pass it off to John to tell us a little bit more about ezetimibe.
Thanks, Laura. Okay, so here's a case that I want us to all think about. This is a case actually that I had in clinic a few weeks ago, so it's very timely. This is a 62-year-old male, history of coronary artery disease and hypertension. He's on atorvastatin 40 and lisinopril 10. He reports adherence to diet and exercise, denies myalgia or liver issues, but he has family members with reported statin side effects. And so in this particular patient, our goal LDL is less than 70 for secondary prevention. And so what I have here is his lab values. And so when I first saw him, he had an LDL of 140. He wasn't on any non-statin therapy at that time. And then we gave him, we started the atorvastatin 40, and 6 months later his LDL went to 85. So we got a change from baseline of about 55 milligrams per deciliter, 39% reduction, but not quite at goal. And so sort of using that as a segue into the IMPROVE IT trial to talk about Zetia. So briefly, Zetia is a non-statin drug. It works in the small intestine primarily to reduce dietary cholesterol absorption. So our statins, as many of us know, reduce cholesterol synthesis in the liver. And so this has an entirely different mechanism of action, which does offer us a little bit of additional lipid lowering without the side effects that are generally seen with statins. The IMPROVE IT trial itself was a very seminal and very important trial back in 2015. And really, these investigators wanted to know, among individuals with recent ACS, does adding ezetimibe or Zetia to a statin, and in this case they use simvastatin, reduce cardiovascular outcomes? Just as a background, Zetia actually was approved by the FDA earlier, several decades before, in the early 2000s, to reduce LDL, but it hadn't actually been shown to reduce outcomes. So this was the first, big outcome trial. And so it was multi-center, double-blind, randomized control. And these patients were high-risk patients, so age of greater than 50 years old, hospitalized in the prior 10 days for ACS, or they had high-risk unstable angina. And they were able to randomize over 18,000 patients. One arm was simvastatin plus placebo or monotherapy. And then, of course, the other arm was simvastatin 40 milligrams plus Zetia 10 milligrams. And on the right here, you see the baseline characteristics of the two groups, very comparable in terms of their demographics because it was randomized control trial. So many of these factors were balanced well across the two groups. And these trialists had the primary outcome of composite CV death, non-fatal MI, unstable angina requiring hospitalization, or coronary revascularization, or non-fatal stroke. And so what this trial really showed in terms of lipid data was that at 1 year, the simvastatin plus Zetia arm had an additional 24% lower LDL versus the statin monotherapy arm, which was about 17 milligrams per deciliter. And we actually saw significant reductions in most lipid markers, total cholesterol, triglycerides, non-HDL, ApoB, and even high sensitivity CRP. And importantly, the primary outcome of the composite CV mortality, major event, or non-fatal stroke was significantly reduced in the simvastatin plus Zetia arm. And so if you look at the Kaplan-Meier curve on the right, the hazard ratio of 0.93 shows us that a relative risk reduction for the primary outcome of 6% and with a significant p-value. And then if we look at absolute risk reduction, it was actually 2%. So there were 32 events, 32.7% of patients receiving simvastatin plus Zetia had an event versus those in the monotherapy group of 34.7%. And so what this tells us as clinicians with an absolute risk reduction of 2% is that number needed to treat is 50, which is, I think, very, very robust, fairly low. If we treat 50 patients, we can help prevent one event. In terms of potential side effects that many of us might be worried about, they actually had pre-specified muscle, gallbladder, and hepatic adverse events, and they were found to be similar amongst the two groups. And so really what the IMPROVE-IT trial showed was it was the first trial to show that adding a non-statin therapy to a background statin therapy not only further lowered LDL-C, but importantly reduced cardiovascular events, which in turn supports the LDL hypothesis that if we lower lipids, we can lead to improved cardiovascular outcomes. So considering this, when we come back to the guidelines, I always like to think, where does this fall in terms of our toolbox? Where should we use it? And the guidelines make, I think, a really good sort of clear label here. And so in this particular patient, right, he is less than 75 and he's on atorvastatin 40, but really his goal needs to be less than 70 and a greater than 50% reduction in LDL. And so the guidelines here give a class 2B recommendation that if a patient has not met that goal, that we can consider Zetia. And so in this patient, it's very, very reasonable to add Zetia, especially because what he expressed to me was that his family members actually had adverse events to higher intensity statin. And so he basically told me up front, I'm really not interested in increasing the statin. I don't really want to run the risk of having myalgias. So in that context, I think it was a very reasonable thing to do. We added Zetia, and he came back 6 months later. He had an additional 25% reduction in LDL, which if we look from the total baseline to where he is now 1 year later, that's a 54% reduction. So we were able to meet the goal of getting him under 70 and having a greater than 50% reduction in LDL just by adding Zetia to his atorvastatin.
John, that's a great review. Thanks so much. I think, as we talk about how these drugs work in real life example, it's helpful to just go through a tiny bit about how the liver is very greedy. So when we use medications that help lower the production of cholesterol inside the liver, it's like, I want more. And so drugs that help lower the production would be statins and also bempedoic acid versus the Zetia is really blocking the absorption. So when we're able to lower the production inside the liver, it will send out more receptors to suck that cholesterol out, which is different than the PCSK9 pathway that my colleagues will talk about shortly, which really helps block the enzyme that gobbles up and recycles those receptors so that we have twice as many sucking cholesterol out. That's my technical jargon there, but I think it's helpful to bring it back to the basics. But we'll move on to bempedoic acid because this comes in a combination tablet with Zetia. So they go along really well together. And I'll start with our second case we'll review today. So I had a 52-year-old gentleman who had a STEMI in 2022, got a stent to the LAD, and then a non-STEMI in 2024. And it was small vessel disease. Medical management was advised, which is really, let's be honest, lowering cholesterol, the biggest lever we can pull to really help lower the risk of future events. Now you can see when he, after his heart attack, he was put on rosuvastatin 40, and we kind of get stuck in inertia. His LDL was hanging out at 131, even though the goal is under 70. So he needed, at least a 50% reduction. But thankfully was referred to the lipid clinic after his non-STEMI in 2024. And earlier, he had been prescribed PCSK9 inhibitors, and he had warned them that he had a needle phobia, and his sweet partner had given him an injection, and he passed out both times. So they both were like, we are not trying it again. So we added the Zetia. You can see on June 20th, so his LDL went down from 131 on rosuvastatin from a baseline of 210 on rosuvastatin for years, down to 112 on ezetimibe. We had our lipid clinic consult, and I added bempedoic acid, expecting, roughly a 20% reduction, which is what the Clear Outcomes trial we'll review has shown. But he had an amazing response. His LDL went from 112 to 41. And I put, after that, his partner stopped making him pass out, and she saw that his cholesterol was to a goal. I'm not saying it was a coincidence that they got married after that, but I'm also not saying it isn't. So it was exciting when they came to share that after that August visit that they had gotten married, getting his LDL to goal and not passing out anymore. So for him, he had a great response to bempedoic acid. And I have seen this in a few of my patients where I'm suspicious they might have familial hypercholesterolemia with very high LDLs. And we try different medications because they work differently with that mutation. And he had a great response. So he is doing well and married after that. So what does the evidence say? So the Clear Outcomes trial is a pivotal cardiovascular outcomes trial. So as we do research, we do phase 1 trials, make sure they work for animals. Phase 2, they're safe. They do what we think on paper. And then at the end, we do cardiovascular outcomes trial. Does it actually prevent heart attacks and strokes? And we found some really exciting findings. So what makes bempedoic acid a little different is that it's a prodrug, and it's converted to active coenzyme A form by enzymes only found in the liver, not in the muscles. This is why we think people have side effects on statins, is that the enzyme that it affects we have in our muscles. And so we're able to avoid some of those side effects by using this prodrug. They enrolled almost 14,000 patients and watched them for over 40 months. And I love that they included primary prevention. 30% of the enrolled patients were primary prevention and 70% secondary prevention. They'd already had an event. And what they found after those 40 months is a relative risk reduction of heart attacks by 23%, revascularization by 19%, and reduced 4-point MACE by 13%. And you can see the mean percent reduction of the LDL was significant there in the orange is the bempedoic acid compared to the placebo. Now, to enroll in this trial, it is the only trial where patients were on a baseline statin since statins have been invented. Patients actually had to sign a form that they understood the risk of not being on a statin in order to enroll in this trial. And so we can use lots of other non-statin drugs, and I certainly do, and when times call for it, but really this is the first cardiovascular outcomes trial that really put a pen to paper here to say we have a therapy that works well without statins. And so we found that because it's along a similar cholesterol production pathway in the liver, that it doesn't lower the LDL as much for people on statins, but up to 20% for statin intolerant patients. And if you put it in the combination tablet of bempedoic acid, 180 milligrams, only comes in one dose, and ezetimibe 10, you get a 38% reduction in the LDL. And as we saw in my first case, some people get even more of a response. And that patient, many of my patients, I see a lot of people who can't tolerate medicine. We'll start one at a time. And then once we make sure they can tolerate both, we'll do the combination tablet, which they love to lower pill burden. What's also unique is they saw a change in the hsCRP, that high sensitivity C-reactive protein that's thought to be specific to inflammation in the heart muscle or heart blood vessels in between levels. So optimal is under 1, normal is under 2, and then between 2 and 10, we're suspicious that there's some inflammation there. So we had a 20.6% reduction in the hsCRP, and unlike some of our statin trials, no change in blood glucose. So this trial really set new standards, enrolled almost 50% women, 48%, high enrollment, 17% of Hispanic patients with and without cardiovascular disease. So we can feel really confident talking to both primary and secondary prevention that we have a good tool in our toolbox for them. We found that patients living with obesity were 23% less likely to experience a major adverse cardiovascular event compared to placebo. And I think we found this in our ezetimibe trials too, and statin trials. All of the trials, the more risk factors you have, especially if it's for secondary prevention, but the more risk factors you have for primary prevention too, the lower the number needed to treat. So that's important to keep in mind as well. There were a few side effects just to keep in mind, but the prevalence was fairly low. A 1% higher increase in the incidence of gout and 1% higher risk of gallbladder stones. That did not lead to gallbladder surgery or gallbladder attacks, just might not give it to someone who's got a gallbladder full of stones already or has a lot of issues. And then there has been reported some tendon issues. And so 1.2% versus 0.9% in the placebo. There were about 11 cases in the first trials using bempedoic acid, but it was a little bit more than placebo. And when they looked at it, it was much more common if that patient had had a history of a tendon rupture, if they're on a fluoroquinolone antibiotic, or if they're on steroids. So it's just a conversation. Often patients are coming to me asking about it because they've Googled it, and I rest assure them that, you're low risk. Let's make sure you don't have any risk factors for this and just cover it that way. So I'll end on this second case, which is kind of highlights how we can manage some potential side effects. So Miss X is a 74-year-old with a history of a ST elevation myocardial infarction. She had a stent in the LAD in 2019. She had tried 4 different statins, Zetia, Praluent, and Repatha, and did not tolerate any of them. And if you have ever heard me speak before, you know I love lifestyle medicine. And so I always say, we've got a couple months to work on that while we try to figure out something else. But her husband was on a renal diet, on dialysis, so it was really hard to make lifestyle changes. So when I first saw her in March of 2023, her LDL was not particularly high at 115, and her uric acid level was borderline elevated, but she had really exhausted a lot of the therapies we could use. So she agreed, let's start bempedoic acid. I kind of gave her the warning symptoms of gout to look for. And when we checked, her LDL dropped to 47 in June of 2023. Her uric acid level had gone up, but she had no symptoms of gout. So we both felt very comfortable continuing on the medication. She had never felt well on the cholesterol medicine. So she's like, this is worth it. If it's just a number, it's okay. It was almost a year, April of 2024, where she called with gout symptoms, painful, hot toe, big toe, and her uric acid level at that time was 12.1. So we stopped the bempedoic acid, we started allopurinol and colchicine. She felt much better pretty quickly, and a few months later, we checked her LDL, had come back up, almost doubled, 105, and her uric acid had come back down into the normal range at 5.9. So then she said, let's try Repatha again. She had side effects. So then finally in January of 2025, she said, that was the one medicine I didn't have any adverse reactions to in my muscles or my cognition or my blood sugar. Is there a way we can manage the uric acid? And so together we decided to start allopurinol, 100 milligrams a day with the bempedoic acid, and her LDL dropped again down to 58 to goal, and her uric acid level was in the stable range, and so without any symptoms. So I think that kind of outlines that there are potential side effects with these drugs, and it doesn't really matter if they're common that we know of, or if they're not. I'll tell some patients, your hair may turn purple, and I will say, I've never heard of that, but let's go ahead and try something else. Gout, it's pretty easy to tell if that's a side effect. And so we have to be willing to hear patients and meet them where they're at. And sometimes it is that they want to continue the medication, not always that they want to stop it. So I love this ad hoc analysis that's hot off the press. It just came out in JACC Advances last month, and they dove into the gout adverse events, and they were reported in 3.1% of the patients on bempedoic acid and 2.1% of the patients on placebo. And you can see here that about 5% of the patients at baseline were had gout before they were in the trial, and about 5% of patients on the placebo had gout before. And they did add, some of these patients were on allopurinol, and some was added during the study as well. When they looked at the actual increase in uric acid, it was about 0.8 milligrams per deciliter. Our patient had a higher level than that, but on average, I think it's important to see it's not always sky high on average, and that when in the trial, in the Clear Outcomes trial, when they initiated a uric acid lowering medication, it did reduce the incidence of subsequent episodes. So I hope that answers some of your questions about bempedoic acid, and you can add that to your toolbox as well. I'd love to pass the torch to Kevin Niles to tell us a little bit more about PCSK9 inhibitors.
Thank you, Laura. I appreciate that. And, I really appreciate this entire little crash course on lipid management. So happy to be here and excited to help present. So, I wanted to start my conversation as well with a case study. So, this might be a little bit different patient than we normally see, but this is a 51-year-old patient, athlete, does everything he can, exercise, diet, and still struggles with high LDL. So patient has had a long-standing history of hypercholesterolemia. He also mentions that he had multiple episodes of rhabdomyolysis after intense workouts. And we're talking really intense workouts, like running a marathon. And that's why he's had a lot of reluctance to start statins. Really afraid of these muscle-related side effects. So the patient initially started on ezetimibe, and that therapy failed to lower his LDL. So he does agree to a course of statin therapy, but shortly into that course of therapy, he comes in complaining of muscle fatigue and soreness. So we draw his labs on that visit. Total cholesterol is 209. His LDL is 151. Now, previous LDLs were as high as like the 180s, 190s. So he's had some reduction with the statin therapy that he's taking, but he admits that he's been very intermittent with it. Depending on the muscle soreness, depending on his workout schedule, he's not been taking it consistently. So we really need to consider some other options for this patient. He does have a family history of hypercholesterolemia and a family history of cardiovascular disease. So he brings that up and he's kind of worried. This is all leading us to kind of be suspicious if there's a familial hypercholesterolemia going on here, FH. So I think in order to get a little better understanding of how the PCSK9 inhibitors work, I put up a picture here. So this is a depiction of a hepatocyte, and you can see on the A, the hepatocyte, there's LDL receptors that line the cell wall, and their job is to kind of grab onto the circulating LDL in the bloodstream, internalize it into the hepatocyte where it gets digested, broken down. The hepatocytes can take care of that LDL, use that nutrition, and they recycle the LDL receptor back to the surface. Now, some patients, particularly the FH patients, have some mutation or upregulation of their of PCSK9. And PCSK9 is a molecule that is secreted by the liver. And what that does is it binds to these LDL receptors and the LDL complex, which again gets internalized into the hepatocyte. But instead of digesting the LDL and recycling the LDL receptor, the entire complex gets degraded and digested. And so patients with this PCSK9 upregulation have less LDL receptors on their cell membrane. So if you give a PCSK9 inhibitor like evolocumab, you stop this interaction and you block the PCSK9 protein. You can move on to the next. So does that work? So that's the theory behind it. And does that work in patients? And so I looked at one of the phase 3 randomized control trials, one of the larger ones done. This was the Mendel 2 trial. This was published in, I think, 2014, where they randomized control. They took 3 arms of patients. They took patients on a placebo. Second arm had patients who took ezetimibe, and the third were patients who took the evolocumab injection. So you saw in this trial, the patients had about a 50% reduction from baseline in their LDL levels in the group that took the evolocumab, and a 40% reduction in the LDL compared to the patients on ezetimibe. So really what it showed us was that evolocumab was significantly affected LDL levels, reducing them compared to placebo. And it also reported very few side effects. So basically a safe and effective result for that. To further that, how does that translate into future outcomes? And kind of what Laura spoke a little bit about was, does this reduce the risk of cardiovascular events? So to further that study, they looked, the FOURIER trial was done. And this was a very large randomized control trial, included almost 28,000 patients. And these patients already had atherosclerotic cardiovascular disease to begin with, and were on a statin. So they kept patients on their statin therapy, and they added PCSK9 to inhibitor evolocumab to one group. Those patients started the study with a mean LDL level of 92, and the patients who were giving evolocumab, they dropped their LDLs down to the 30s as a mean range. So very low LDL levels and a very great reduction. And after about 2 years of observation, they had reached a endpoint showing that there was a decreased risk of cardiovascular events. And those cardiovascular events were defined as MI, death, stroke, unstable angina, and revascularization. So they actually ended that study a little bit early. They were originally planning to go out 4 years on that, but because their results were in, it was statistically significant, they ended it there. But they continue to follow these patients in the FOURIER open label extension trial. And this one, they added the evolocumab to both groups and followed them out for as long as 8 years. And once again, they showed over 8 years there were still no significant side effects other than injection site reaction. And the rate of cardiovascular events continued to decrease. So the relative risk from FOURIER was about 15% relative risk reduction, and it was at about 20% in the FOURIER OLE at 8 years. I think it's actually 5 years. But so the next question, couple questions here is, and I like that opening slide, Laura, where you showed that there's almost no one getting the PCSK9 inhibitors, in a lot of those groups, it's very, very low usage. And we can talk about why in the Q&A, I guess. But but it sort of brings to the conversation, should they be being used more frequently, and can we tailor a regimen specifically for certain patients? So certainly patients who have familial hypercholesterolemia might be considered. Patients who don't have any of the modifiable risk factors, these are the patients we kind of look at. I think it's important to point out that some of the studies show that less than 1 in 4 patients don't achieve their LDL targets with statins alone. Less than 50% of patients who are started on a statin remain adherent to it at 1 year, and if they do have myopathies, they'll lower their dose or they'll discontinue therapy entirely. And especially in light of the newer guidelines, which are for high risk, the ACC high risk is LDL less than 50, and the European Society extreme risk, they want it less than 40. Can we hit that without going to, double therapy, dual therapy, triple therapy, or quad therapy? Is there a role to use PCSK9 inhibitors as a monotherapy and even more as a first line? I think is worth the questions.
Great summary, Kevin. Thanks so much. I think this will be a great segue into another drug along the PCSK9 pathway. Viet, take it away.
Okay, thank you. So inclisiran, this is another PCSK9 interfering therapy. And folks get a little confused and think that it's somehow different. It targets the same PCSK9 protein molecule, but in a different mechanism. So coming back to Kevin's pictures that he showed, the graphic of LDL receptor, I want you to think of LDL receptor as the garbage truck. It comes out, picks up LDL cholesterol, brings it in, dumps it at the landfill. But PCSK9 is the micromanager that we all just thoroughly love, micromanaging us. And it hops on that garbage truck and says, hey, show me what you're doing. So you do, and then you get fired. So that's the problem with PCSK9. So if we can go a little upstream, PCSK9 monoclonal antibodies are like that coworker that will interfere with your boss and bind them up so that you can do your job. But you have to do that every 2 weeks because they get tired. You have to rotate out, you know. Small interfering RNA is like going upstream and saying, let's not graduate these micromanagers. They don't need their MBA of not awesomeness. And so that's what a small interfering RNA does in this case. It will go upstream to interfere with that messenger RNA, and you do not graduate or create more PCSK9. So it'll reduce the level there, allowing you and your garbage truck to do what it needs to do, right? So about 45 to 55% reduction in LDL cholesterol, just kind of as a mechanistic way of thinking about it. But that's the way I explain it to my patients. This is an interesting case here. This is a 67-year-old woman who had who still has, because she's still alive, familial hyperlipidemia. She had a history of TIAs in multiple small ischemic strokes, prediabetes, and came to us really as a referral because of this last stroke that she suffered. And when we saw her, I was like, you know, an LDL cholesterol of 276 and multiple strokes probably kind of speaks to some type of genetic mutation. And sure enough, it was a heterozygous for LDLR, which is the most common of the 4 mutations for FH. And this is the garbage truck. So think of this garbage truck with, I don't know, broken swing arm, maybe the tires always flat. It's just not being able to do its job. And so LDL cholesterol stacks up because you can't clear it well enough. She's a former smoker, but quit. Family history here, premature. You know, father had an MI, age 54. So you have clinical components here and increases the likelihood without a genetic test of FH being on the docket or in her diagnosis. But this poor gal, she had multiple statins trialed over the years. This is not new. It wasn't like, hey, did you consider lowering your LDL cholesterol? This is not the first time, okay? So folks had tried simvastatin, rosuvastatin, atorvastatin, all the statins. And actually, if you kind of think back, you know, there was even lovastatin and fluvastatin at one point that was trialed. So we're now reaching back, you know, 25 years. So here she comes to us, LDL cholesterol 276. And we kind of did some further. I don't know that we necessarily need to do a calcium score, and we didn't. The primary care provider did. With the history of ischemic strokes, you've got established ASCVD. But surprisingly, the coronary calcium score was not that high. In this case, we were a little bit more thorough when she came to us. HSCRP was 2.9, so elevated. You don't want this above 2. That's that inflammatory marker. Paul Ridker is, you know, will tell you all the time that HSCRP should be low. Her LP(a) was 29, so you know, nothing to shake a stick at. Normal is it's really about 26 or less, but she's in that kind of moderate but barely moderate range for LP(a). And of course, we get an ApoB100 to look at all the atherogenic particles. And hers was a little bit elevated at 112. Well, you got a gal with multiple small ischemic strokes. She has this family history and has coronary disease as well. So an LDL cholesterol at minimum, less than 70. In FH, without events, you want less than 100. Less than 70 is certainly a goal for ASCVD, but I would argue really an ASCVD score, or I'm sorry, an LDL cholesterol of less than 55 is appropriate because of multiple events. So less than 70 is really, you know, kind of like, oh, sure, let's try that when you start at 276. So on, you know, she was trialed on medications, LDL cholesterol 252 by the time that we really got our hands on her. She'd already had xanthelasmas events, and she was started on evolocumab. So let's just see what happens here. And this is a case that has been published. So as we kind of looked through this, evolocumab, yeah, if you follow the gray in the middle there from 250 at time 0. So this is her lipid measurement. So that's the middle bar and kind of where you're going to see where evolocumab did not do anything with this patient. So by the time she ends, she just from start to finish, it just stayed the same. Something about that mutation or something else that was going on. She was not a responder to evolocumab. Still don't know why. Maybe she developed antibodies, but that would have been really quick. So right about that time, at 8 months out, we added bempedoic acid and ezetimibe as a combo, so Nexlizet. And you see this nice, great drop. Fantastic medication. I am a fan of bempedoic acid. And we thought, ooh, pitavastatin is one of those that was developed in Japan by the Japanese population. They have high statin intolerability. We thought, let's just try it. Let's just try it and see. And it was about the same time that we were doing prior authorization for inclisiran. Okay, so now a small interfering RNA, we thought maybe it's the monoclonal portion of it, the way that evolocumab or Repatha, just something about that wasn't working. But we decided inclisiran here. And you can see this sharp drop from 250, of course, bempedoic acid crossing over with pitavastatin being started down to 150, and then both pitavastatin and inclisiran together. So you can argue, is it pitavastatin, is it inclisiran? But she drops all the way down to 68 there. And that is astounding in someone that starts at a 276, in this case 250, to try to drop down as far as we could. Well, unfortunately, on this pitavastatin, she started to have symptoms of myalgia again. And we had to kind of reduce the dose of her pitavastatin down to 2 milligrams. And that uptick there that you see on the arrow is to 113. And then the last follow-up was an LDL cholesterol that she achieved of 93. This is 6 months after her second injection of inclisiran. So really, pitavastatin's kind of off and on. We went from 4 milligrams to 2 milligrams, but she's holding steady here after the second injection of inclisiran and a reduced dose of statin. In the end, this is someone that is on quadruple therapy. Okay, bempedoic acid, ezetimibe, inclisiran, and pitavastatin, which is kind of low dose, and she's playing around with every other day, etc. But with 4 different high-powered therapies, still hovering just under 100. So it's kind of a difficult thing, but inclisiran in this case allows us to do 2 injections a year. Again, you've shut down that college, and you're not creating PCSK9 as often, and therefore you can inject it every 6 months. But as you started up, just remember, you have a baseline, you have to do 90 days, and then you convert to every 6 months after that. So the first year for anyone starting is 3 injections. So because of the myalgias, her pitavastatin is 2 milligrams once a week. And through this time frame, now we followed her forward for another year. At this point, she's staying right between 100 to 121. It's kind of floated up because of pitavastatin once a week, but no further events in someone that was having small, TIAs essentially on a regular basis. And so we're pretty happy with that. Can you move forward to, yeah. So let's talk about this. The Victorian, now there's been multiple Orion trials. This is one of those therapies like ezetimibe that came through first as an LDL cholesterol lowering therapy. Still, we do not have a cardiovascular outcome trial per se. The current Victorian trials are not necessarily powered for major adverse cardiovascular events. The Orion 4 trial started in 2019. I am a sub-investigator, full disclosure. And we hope to see events reported out in next year, 2026. So keep your fingers crossed. At minimum, I'm now conjecturing as a clinician and as a clinical trialist, at minimum, we should see about a 15% relative risk reduction, similar to evolocumab and alirocumab, Repatha. But I'm hoping that there will be a little bit more. So the Victorian Initiate study is looking at really initiating these therapies as quickly as possible. So, folks, rather than waiting, we start a statin and then we initiate inclisiran. And what you see then, I mean, these are the visits, they're based on, injections. So that's okay here. This is adults with a history of ASCVD and LDL cholesterol still above 70, maximally tolerated statins. So go ahead and go to the next slide. And what you'll find here is that versus usual care, you already gave us the data, Laura. We do not do well in usual care. In fact, it is substandard usual care. I'm sorry, this is what happens in healthcare 1.0. We need to go next level. And so at minimum, when you start something like inclisiran, it does its own job. The patient doesn't have to remember a daily medication. They don't have to remember to inject themselves every 2 weeks. This is something we provide. We inject as clinicians. We schedule the patient in, we remind them, they have a 90-day time frame from when their injection should occur, and then we inject them. And you can see this is 51 to 60% reduction in their LDL cholesterol. So Victorian Initiate is a win here because it's based compared to usual care. Again, this is what we're up against, 7% reduction versus this. So in the end, this is really the first, this is about my case 4 conclusions. First case that shows a patient's refractory response over time with PCSK9 monoclonal, and then a subsequent favorable response using small interfering RNA, inclisiran. So the mechanism for why there was refractoriness on evolocumab, I don't know, but I'm grateful that she responded to small interfering RNA. So I'm going to turn it over to Camille so that we have time. Sorry, I get a little verbose, but thanks.
That's great, Thea. Thanks, Camille. Tell us more about icosapent ethyl.
Well, thank you for this opportunity as we transition from LDL, the world of LDL, and into triglycerides. So this is a patient I saw 2 Saturdays ago. It's a 67-year-old female with a past medical history significant for hypertension, hyperlipidemia, and COPD secondary to secondhand smoke exposure. She presents with Apple Watch heart rate of 120, shortness of breath, coughing, wheezing for 2 to 3 days. She was noted to have an elevated troponin, and cardiology was consulted for further management. Her home medications include amlodipine 5 milligrams daily and atorvastatin 40. Laboratory studies revealed troponin of 17, 21, and 25 with a BMP of 880 and a TSH of 2.560. Her lipid panel revealed a cholesterol of 152, triglycerides 207, HDL 59, and LDL 52. So what should we do next? Next slide. The reduction of cardiovascular events with icosapent ethyl intervention trial, otherwise known as the REDUCE-IT trial, involved 8,179 patients randomized for a median of 4.9 years. And this was a secondary prevention trial. This is a multi-center randomized double-blind placebo-controlled trial, and they were randomized to either 2 grams of icosapent ethyl twice a day versus placebo. And the inclusion criteria were hypertriglyceridemia, statin treatment, maximally tolerated statin, age greater than or equal to 45, established cardiovascular disease, or age greater than 50, diabetes, and 1 additional cardiovascular risk factor. There was a result of primary endpoint for the icosapent ethyl group of 17.2% and 22% for the placebo group. Next slide. So when we look at the forest plot, we see that most of the endpoints fall to the left of the line of unity. And it shows us that icosapent ethyl was better in all of these situations or endpoints compared to placebo, with the exception of death from any cause. So that include your endpoints were primary composite, key secondary composite, cardiovascular death or non-fatal myocardial infarction, fatal or non-fatal myocardial infarction, urgent or emergent revascularization, cardiovascular death, hospitalization for unstable angina, fatal or non-fatal stroke, death from any cause plus non-fatal myocardial infarction or non-fatal stroke. So all of these endpoints fared better than placebo in the icosapent ethyl. And when you look at death from any cause, the only difference compared to the death from any cause plus non-fatal myocardial infarction or non-fatal stroke was the inclusion of those two characteristics. And so it really reinforced that death from any cause was worse because it did not include the benefits of non-fatal MI and non-fatal stroke. When we look at the Kaplan-Meier curves, we see that it's at about 2 years where the curves diverge. And why that is important for us clinically is that it means that patients need to be on the 2 grams twice a day for 2 years to get the maximum benefit of the drug. And the other important finding in the study was seen that the separation or divergence remained throughout the rest of the study. So that is very important. When we look at further statistical analysis from this study, the number needed to treat to avoid one key secondary endpoint event was 28 over the 4.9 years. And the risk assessed in the primary composite endpoint of cardiovascular death was lowered by 25%. And the risk of the key secondary composite endpoint of cardiovascular death was lowered by 26%. Next slide. So what is EPA's function? EPA's chemical structure enables it to modify the cellular membrane and insert itself in places of other fish oils, such as arachidonic acid. We know that this chemistry is important because EPA is the antithesis of arachidonic acid. Arachidonic acid promotes inflammation and thrombosis through mediators such as prostaglandin E2, leukotriene B4, and thromboxane A2. These mediators are important in increasing vascular permeability and vasodilatation, thus promotes platelet activation and aggregation, which is what we don't want. Some of the possible adverse effects that we see with EPA is increased risk of bleeding, 12% versus 10%, musculoskeletal pain, 4% versus 3%, peripheral edema, 7% versus 5% in placebo, constipation, 5% versus 4%, gout, 4% versus 3%. And I saved this one for last because this probably caused the most pause for users of the drug, was the atrial fibrillation risk of 5% versus 4% in placebo. However, they did not find an increased risk of stroke despite the increased risk of atrial fibrillation. We also need to be mindful of some of the drug interactions, which would include the anticoagulants, all of our oral anticoagulant agents, the antiplatelet agents, clopidogrel, prasugrel, our non-steroidals, all can potentially interact with EPAs. Next slide. So what's the difference? We know that all fish oils are not the same, and arachidonic acid and docosahexaenoic acid, DHA, do not provide the same beneficial cardiovascular benefits as EPA. EPA is chemistry is very important, and IPA is an esterified version of EPA and is a prodrug with primary mechanism in lowering triglycerides. So we get an increase in anti-inflammatory mediators, an increase in anti-thrombotic mediators, which overall improves endothelial function. And furthermore, IPE, or icosapentaethyl, was the first fish oil approved by the FDA to reduce the risk of atherosclerotic cardiovascular disease. So that is why it is important for our patients to have this option. Thank you. And I'll turn it over to Laura now.
Thank you. Thank you for pronouncing the hardest words in this whole presentation. So I really appreciate it. I think the part I'm the most excited, well, I'm excited about this whole webinar, but really, how do we get the medication to the patients? Now that we have shown you the toolbox, right? How do we get it? And you will see these are actual hoops and red tape. I have jumped through and I have photographed for you so that you too can get a letter like I have outlined at the very top. We assess the facts of your case and determine that our first decision to deny coverage for this service was incorrect or that medication. How do you get letters like this where they reverse coverage? Here are some tips. So to get non-statin medication that's not generic, for secondary prevention, it's pretty easy if someone's had a heart attack, stroke, a stent, anywhere head to toe. But also, I've had a lot of success if they've had any MRI that showed microvascular disease, can call that secondary prevention. If they have ever had a carotid artery ultrasound and it shows a 20-30% blockage, certainly want to keep an eye and be aggressive, but not enough traditionally that we think of secondary prevention. That all counts, and I've had a lot of success with insurances covering those diagnoses to get these drugs covered. For primary prevention, it can be a little bit trickier, but it's gotten much easier just in the last few years. So if someone's LDL is over 190, we know that's kind of the poor man or woman's test to say that they might have familial hypercholesterolemia. So if you just write that down, they didn't tolerate statins or their LDL isn't to goal despite maximally tolerated statins, you can often get these non-statin drugs approved. If their coronary artery calcium score is over 300 or more calcium than 75% of people their age and gender, often there is success in getting these medications covered. If you are able to offer familial hypercholesterol genetic testing, I have yet to have an insurance company say, nah, we're good. We're okay with that 50% risk of a heart attack by the time they're in their 50s if we don't get their LDL down. So we're involved in a study at my institution that covers this test for free. So I think even through there's many foundations out there, FH foundations that will allow you to do free testing. And then you can also do the Dutch or Simon Broom criteria. It's kind of a counting system that will say it's likely or not likely, and you can submit that to the insurance. And then I think this is something I only found out in the last few years, is that all Medicare patients have access to the HealthWell Foundation grant. So again, patients have to be over 65, but the amount that patients have in their income for a family of two is under $100,000, and they would qualify for this grant. And through Medicare, there's buckets of money for different disease states. So they have a bucket of money for patients with hyperlipidemia, and if you have a family of two who makes under $100,000, they get a $2,500 annual grant. It's for 365 days, and it's renewable every year. So they get kind of like a little card, a credit card that has that much money on it that they can use to pay for any lipid medications, whether it's bempedoic acid or PCSK9 inhibitors. Even Zetia or statins, they can use that medication and then renew it the next year. So sometimes the grant runs out. So in the last few years, it has run out twice in the last 3 years for only about a month or a month and a half. So I just tell patients to keep checking. I've written the foundation here in the website of the healthwellfoundation.org website here in that gray box. And it's thankfully, the amount really captures our patients that make too much to qualify for the drug assistance programs, which is really poverty level. It's up to 500% of the federal poverty level to qualify for this grant, but probably don't make enough to actually cover the cost of the whole medication. And so, yes, I think I just gave some of my experiences where it shut for a little bit and then opened right back up a month and a half later. So if you have any questions, please type it into the chat. Also, you can email apac.contact@gmail.com if you want to join our prevention committee. John Giacona is one of our co-chairs of the prevention committee. If you're interested in planning webinars like this, if you'd like to submit a case to contribute to the APAC newsletter, or have something interesting to write about a new journal article, or if you're in industry and want to learn more about sponsorship, I have to say many thanks to our generous sponsor, Esperion, for sponsoring this webinar where we could really talk about all the tools at our disposal and bring advanced practice clinicians together to connect and learn about the resources out there so we don't have to necessarily reinvent the wheel as well. So let me see if there's any questions here in the chat. I don't think so. I think first I'll turn to the panel. Any questions that any of you have? Otherwise, I have a few that I get from patients that I thought might be helpful. We have about 5 minutes. No? Okay, well then I'm going to start. Viet, I'm your patient. Can I take red yeast rice? Because I want something natural and not a statin.
Okay, so let's go back. What is red yeast rice? This is where we found statins. So go ahead, I guess. But just remember that Moncolin K is what the substance was that we identified statin therapies from, and it's no longer available in any red yeast rice within the United States. So do it. It's placebo. Have fun.
Placebo. But there were some bottles that had arsenic in it. So, I mean, I think there are potentially some risks. I always tell patients, if you're going to swallow something, let's make sure it's something that works and is safe. So that's, I think
Well,
the
let
other,
me back that up just a little
Yeah.
bit. Okay, so no, that's a fair statement, arsenic. But remember, none of the off-the-shelf nutraceuticals are regulated. So arsenic could have been in any of them. This is where it just gets really difficult. But patients will take what they take. I am just a pragmatist and say it's not going to do what you think it does because it's missing this. But you know, if you want to spend your money there, that's fine, but that's not going to be helpful.
Fair. Thanks, Viet. Camille, I was interested in your case study. So, we've got a bunch of experts on the call. Certainly, his troponin was going up. Might not think of icosapent ethyl right away, but let's say one of us saw him in follow-up. I know we talk a lot about residual risk reduction. His LDL was to goal. Kevin or John, what would you do for someone like that if you saw him in clinic follow-up?
John. Yeah, I mean, I think, you have to really take a whole look at the patient and look at, the big picture here. So, there's lots of alternatives that we can go to.
Yeah.
And I think, just need a really deep look at their lifestyle, what else they're on, and what we can do.
Well, now you spoke my love language, lifestyle, right? We can't forget how much that can be a tool in our toolbox. That will be a whole nother webinar. But yeah, so dietary changes on average can increase the LDL up to 20% if they eat, carnivore diet, or decrease it to about 20% if you're really more whole food plant-based. But there are people who do more or less based on their changes. But I do hope that this webinar really touched on the highlights of how many tools we have. And we're just so thankful for all of you joining us. It looks like we have one nice comment, not a question. We're so glad that you could join us and really dive into this important topic. And we're excited to hear from you if you want to be more involved in APAC. I'll use our last minute to talk about our annual CAP conference. This is going to be in Nashville, November 13th to 15th. It's all over our website if you want to join us and meet us in person. And we have cardiology speed dating and speed mentoring. We've got all sorts of great topics and poster presentations. Over 50 posters will be presented. So please register. We'd love to see you there and introduce yourself as well. So thank you for joining us, and we can't wait to plan our next webinar. I hope you all have a wonderful night and feel more armed with some tools to fight this important risk factor of hyperlipidemia. Thank you.